and magnitude of cardiac leaks is unlikely, and the data is limited to fair. Budesonide, the category risk category is D, and the magnitude of cardiac leaks is unlikely, and data limited to fair. Similarly, fluticasone, category C, no data is available. Mometasone C, and the teratogenic effect is undetermined, limited data. And finally, the theophylline, the risk category is C, and no magnitude of teratogenic risk is none, and the data is fairly good. Now the steps of asthma therapy during pregnancy. Step 1, preferred controller medication, none is required. Step 2, low dose inhaled corticosteroid. And alternative controller medication is lipotensine antagonist, theophylline or pomolin. In step 3, medium dose inhaled corticosteroid. And alternative controller medication is low dose inhaled corticosteroid plus LABA or lipotensine antagonist or theophylline. In step 4, the preferred controller medication is medium dose inhaled corticosteroid plus LABA, and alternative controller medication is medium dose inhaled corticosteroid plus either lipotensine antagonist or theophylline. And in step 5, the preferred controller medication is high dose inhaled corticosteroid plus long-acting beta agonist. And in step 6, high dose inhaled corticosteroid plus long-acting beta agonist plus oral prednisone. Now the patient education for self-treatment of asthma during pregnancy. So the general information is they provide basic information about the asthma and relationship between asthma and pregnancy. Use of inhalers, demonstrate proper technique for a specific device and ask patient to perform the technique, demonstrate use of a special device for intradose inhaler. Adherence to treatment, discuss self-reported adherence to treatment with controlled medication and if needed address barriers to optimal adherence. Self-treatment action plan, provide schedule for maintenance medication and dose of rescue therapy for increased symptoms, explain when and how to increase control medication and to use prednisone, explain how to recognize the severe exacerbation and to seek urgent or emergency care. Now the important countermeasures to reduce exposure to allergens. Animal dander, remove pet from house, if removal not acceptable, keep pet out of bedroom. Dust, mite, encase pillow or other mattress with impermeable covers and wash sheets and blankets quickly in hot water. Cockroach, for the allergen cockroach, do not leave food or garbage exposed. Use poison bags or traps rather than chemical agents which can aggravate asthma. Now the management of acute severe asthma during pregnancy. Acute severe attack of asthma are dangerous and should be vigorously managed in hospital. Treatment is no different from the emergency management of acute severe asthma outside pregnancy. Oxygen, nebulized beta-2 agonist, nebulized ipratropium, oral or IV steroid, and in severe cases, intravenous aminophylline or intravenous beta-2 agonist should be used as indicated. Sadly, pregnant women do not receive appropriate treatment with corticosteroids compared to non-pregnant women. Now, management of asthma during labor and delivery. Acute attacks of asthma during labor and delivery are extremely rare. Women should be reassured accordingly. Women may continue their regular inhalers throughout labor. Those on oral steroid at the onset of labor or delivery should receive parenteral steroids. Prostaglandin E2 used to induce labor or ripen the cervix or for early termination of pregnancy is a bronchodilator and is safe. Prostaglandin F2 alpha indicated for severe postpartum hemorrhage should be used with caution as it may cause bronchospasm. Asthmatic women may safely use all forms of pain relief in labor, including epidural analgesia. Opiates should be avoided. Augmentin has been reported to cause bronchospasm. Management of asthma in breastfeeding mother. Women with asthma should be encouraged to breastfeed. The risk of atopic disease in developing in the child of an asthmatic mother is about 1 in 10 or 1 in 3 if both parents are active. The risk may be reduced by breastfeeding. All inhaled preparations, oral steroids and methyl are safe when breastfeeding. Now the conclusion and recommendation. Management of asthma in pregnancy doesn't differ significantly from management outside pregnancy. The priority should be effective control of the disease process, with the aim being total freedom from symptoms both day and night. The medication used to treat asthma are safe in pregnancy, but the concerns on the part of the pregnant woman and their carers may result in the reduction, cessation, or withholding of important treatments. Great attention must therefore be given to the expansion and reassurance about the safety of the drugs used to treat asthma in pregnancy and lactation. Although uncontrolled asthma may increase the risk of adverse perinatal outcomes, women with well-controlled asthma in pregnancy generally have good pregnancy outcomes. Exacerbation should be prevented by optimal asthma management, and if they occur, they should be treated aggressively. Asthma care and obstetric care should be carefully integrated. The patient should be educated regarding the potential risks of uncontrolled asthma for herself and her pregnancy. The small risk of harm to the fetus comes from poorly controlled severe disease rather than from the drugs used to prevent or treat asthma. We should choose inhaled budesonide over other inhaled corticosteroids because more safety data are available on the use of this drug during the gestational period. The patient should also be instructed in the use of an optimal inhaler technique. The patient should be given a personal self-management action plan for asthma. We should recommend follow-up every 1 to 2 weeks initially to ensure that asthma control is achieved, and then once the patient's condition is stable, at least monthly throughout the pregnancy. And thank you so much for kind attention.
Learned audience, Assalamu alaikum. My topics of discussion is bronchial asthma with cardiovascular disease. Bronchial asthma will present simultaneously with many other ailments. One such important comorbidity is cardiovascular disease. It is a common situation for the chest physician to face the patient of bronchial asthma with cardiovascular disease. Sometimes it is very much difficult to differentiate bronchial asthma with left ventricular failure or valvular lesion leads to pulmonary edema. Many other cardiovascular diseases may associate with asthmatic patients, such as hypertension, ischemic heart disease, arrhythmias, etc. Why do you think cardiac disease may be associated with bronchial asthma? Elderly patient present with dyspnea, patients having more crepitation than wheezing, patients with cardiac murmur, patients do not improve with classical anti-asthmatic treatment, patients with unexplained breathlessness. Now I discuss individual comorbid condition, asthma with hypertension. Virtually all antihypertensive in low dose can be used in asthmatic patient except propranolol. Drugs of choice is calcium channel blockers, thiazide diuretics, single or in combination. Angiotensin receptor blockers, that is ARB like losartan, valsartan, are preferred to ACE inhibitors because this may induce dry cough. Non-selective beta blockers must be avoided. Selective beta blockers can be used. Cardioselective beta blockers do not produce clinically significant adverse respiratory effect in patients with mild to moderate severe reactive airway disease. Cardioselective beta blockers should not do effect from the patient of hypertension, ISD, arrhythmias, heart failure with mild to moderate reactive airway disease. There is another comorbid condition, asthma with ischemic heart disease. Aspirin should be tried first. If not tolerated, clopidogrel should be used. Anti-anginal nitrates and calcium channel blockers, that is diltiazem and verapamil, are the drug of choice. Cardioselective beta blockers may be used. Some beta blockers mentioning here: selective beta blockers, bisoprolol, metoprolol, acebutolol, atenolol, non-selective propranolol, pindolol, and nadolol. Asthma with heart failure. This is one more comorbidity condition. Diuretics is the drug of choice. ACE inhibitors should be continued if tolerated. Carvedilol may be used in low dose. Digoxin can be used. Some words on ACE inhibitors. ACE inhibitors lower the systolic, diastolic and mean blood pressure, as it reduces the systemic vascular resistance. It is now clear that